think Pandit madam is joining, na Pradnya?
Yes, yes. I've resent her the link. I spoke to her twice. She will join.
Maria, just talk to Dr. Adi Dastu. He wanted to join. Just find out.
Okay, ma'am.
Hello. Hi, Pradnya.
Hello, ma'am. Good
Hi.
afternoon. Welcome.
Good
Hello,
afternoon.
Suchitra.
Hi.
Good to see you.
Sir.
Hi, Suchitra. Thank you.
Hello. Hello,
Thank
Madhu.
you for joining.
Hello.
Suchitra.
Hi, ma'am.
Good evening,
afternoon.
Sujit.
Suchitra, your face.
Hello, madam.
See, you can
Suchitra,
help me.
ma'am, just lower the screen. We are just
Yes.
able to see
Yes.
half your face. Yes, ma'am. Now we can.
Okay.
Yes, ma'am.
Okay, now better?
Yes, ma'am.
Yeah. Hello. Good afternoon to everybody. Lovely to see all of you.
So should we begin, ma'am? It's 4 o'clock.
Yes, yes. You want to wait? Yeah. We can start.
Yeah. Yes, ma'am. Others will keep on joining. Yeah.
Yes, yes.
Pradnya?
Yes, ma'am. So, a very good afternoon to everyone. I welcome all the delegates, all the faculty members and seniors attending today's program. Today is our 7th episode of Clinical Pulse of JOGI. To begin with, we would like to start with Saraswati Vandana.
सरस्वती नमो नमः विद्यादायिनि नमो नमः हंसवाहिनी नमो नमः ॐ सरस्वती नमो नमः मा सरस्वती नमो नमः विद्यादायिनि नमो नमः
I now call upon our EIC, Dr. Madhuri Patel. Madam is the Secretary General FOGSI. She is the EIC of Journal of Obstetrics and Gynecology of India. Madam is Joint Secretary FOGSI 2009. She is Honorary Clinical Associate at Vadia Hospital.
Pragna, thank you. Pragna, thank you.
No, Madam, I'm sure Madam does not need any introduction. So over to you, Madam, to talk to us about the clinical pearls of Jogi.
Can you stop sharing so I can see everybody? Hello, can you stop sharing? Who is that control? Who is the host?
Ma'am, we have stopped screen sharing.
Stop.
Can you speak?
My thing, okay. Okay, gallery view. Okay, yeah, right, yeah. So, respected our President, Dr. Jaideep Chan, and today's guest of honor, Madam Usha Saraya. She is my mentor, guide, and I have learned my OBGY under Madam. And I learned lots about the cervical dysplasia and cervical cancer because Madam has been conducting this since last 45 years. The program every year where she trains, in cytology and colposcopy, and she must have trained thousands of people, thousands of our members for this course, during this course. And she's continuing. I see her dedication. At that time, I feel that we should keep on working like this for the woman's health, and we should work for improving the woman's health. So, Madam, nice to have you over here. Then my dear friend, Dr. Suchitra Pandit. She is also past president of FOGSI. Madam is also past president of FOGSI. And Suchitra, we were contemporary. And with Suchitra, I have worked for a long time. We were examiner together. We had a good time everywhere. And Suchitra, very nice to see you. I welcome you. And today's most important person, another person is my mentor and guide along with CN Purandare, is Sanjay Gupta sir. He's always there. Always there, and I'm so happy that today he's going to present. He's an author, and today he's going to present his case report, which is very very I felt it was very nice to learn for everybody. Now, what happens, sir, when presenting and other, last time Dr. Putambekar presented, before that Dr. Trivedi presented. So we learn, the juniors who are, having aspiration, they really learn from them. So very nice to accept our invitation, sir. Then we have Dr. Editor Emeritus, my mentor, Professor C.N. Purandare sir, Professor Aditya Su, Dr. Suvarna Khandikar, Dr. Geeta Basalkar, today's chairperson, Dr. Sujata Dalvi, associate editor. She's always there with me in all the editors' work, and I'm really thankful to Sujata for the same. And the other chairperson, Dr. National Corresponding Editor, Dr. Sampath Kumari, Dr. Radhika AG, they are all my best friends, and we help each other in the journal as well as in the other function of the FOGSI. Then our editorial team, Dr. Arun Nayak, Dr. Anahita Chavan, Dr. Ashwini Balerao Gandhi, Dr. Pragna Changade, secretary team, Dr. Pragna Supe, Dr. Sumil Tambewakar, and my national coordinator, corresponding editors, Dr. Krishnendu Gupta, Dr. Lakshmi Shrikande, Dr. Sushil Chawla, Dr. Radhika, Dr. Kiran Mai, Dr. Shova, Dr. Deepti, Dr. Mala, Dr. Alka Pandey, Dr. Srivas Madhva Prasad, Dr. Krishna Kumari, Dr. Sampath Kumari, Dr. Ramni Devi, Dr. Ashok Kumar, Dr. Subhash Chandra Bishwa, Dr. Nidhi Gupta, all my reviewers and all my dear friends. A very good evening to all of you. It is with great pleasure and anticipation I welcome all of you for this 7th episode of FOGSI JOGI, that is a clinical pulse of JOGI, an initiative by our JOGI team. I was just thinking before taking over as an editor-in-chief that what I can do new things, because every time we have a PICSEP program on research methodology, then with ICOG also we have tied up for the research methodology and journal flow. And last time Dr. Geeta has done, from British Journal, the courses, and that was also very good. So I was in America before the conference, before the taking over, and that time I just talked to my son-in-law. He's also an editor in elsewhere. So he told me, okay, Mommy, why don't you start this clinical pulse of JOGI? You call them, because they have written to your journal, because every year we get more than thousands, 1100 to 1200 papers, and we have to select only 110. So after scrutinizing, peer reviewing, they have come, we have published their work. So why not to call them, and we give our authors chance, because every time we go for the conference, there are very few people to listen to their work, research work. So at least this platform from JOGI can talk about their work, and the juniors who has aspiration, they can pick up the same topic and do more work in that. So that will motivate everybody. So this time I am very happy. Apart from our members, FOGSI members, we have now today this time international member also. So first topic is, it is a case report, newborn genetic screening, significance in early diagnosis of an infant with mitochondrial DNA duplication syndrome 6. So this is a really new topic for majority of the general gynecologists and obstetrician. And I selected so we can have a discussion, and everybody knows that what we can do after the baby is born, because everywhere the screening is conducted in a major institute after the baby is born. So this is one more thing, we can do the screening, and we can at least counsel the parents and what we can to prevent the complication. Then Dr. Vera She's a trans sector. She's going to talk on trans sector ultrasound in cervical cancer, a systematic review of its current application, which we have published recently in our journal. And I thought, okay, we are aware about the transabdominal sonography, we are aware about the transvaginal, but transrectal in vagina and cervical cancer, how it is be useful. So I wanted all gynecologists and obstetrician to know that there is a use of transrectal, or sonography, especially for cervical cancer. There are so many implications in that, which Dr. Vera is going to talk to us. Thank you, Dr. Vera, for accepting our offer. And then we have Dr. Divya Bhalchandra. Her best paper title is Adrenaline Crisis in a Patient with Autoimmune Polyglandular Syndrome 2 during pregnancy. So it gives us the idea that when the pregnancy is there, we always attribute that the first trimester nausea, vomiting is attributed to the pregnancy. And we have to really think that the patient does not recover with your routine treatment. You have to think about the other disease also, which Dr. Divya is going to talk about it. So I'm confident that this initiative will immensely benefit the aspiring contributors. And now I invite my MOCs, Dr. Pragna Supe, Dr. Pragna Changade, and Dr. Sunil to continue the further proceeding and let us embark on this enlightening journey together. Thank you very much for giving me this opportunity.
So, good afternoon, everyone. Thank you so much, Madhuri Patel, madam. So, this whole, as madam explained, this whole program has been madam's brainchild, and we have had 6 successful programs. And this time we wanted to do something different because we have always been, presenting original articles. And madam thought that, we should include variety of articles, and that is why we have a meta-analysis and 2 case reports. So the chief guest for today is our very own FOGSI president, Dr. Jaideep Tan. Can I have his slide, please? So we all know, sir, he is the president of FOGSI, chair of IGA committee for project lead FOGSI USAID projects. He has been the secretary general of FOGSI. He's been awarded the FRCOG honoria causa. And he is the consultant at Ashwini Maternity and Surgical Hospital at Ghatkopar. Sir is the immediate past Deputy Secretary of AOFOG, immediate past chair of the FIGO Committee for Safe Abortion. He has been instrumental in drafting various proposals for FIGO, developing a project for MOGS for assisting underprivileged women. And he has led FOGSI for whether it is, FOGSI statement on hysterectomy rates, cesarean rates, and Supreme Court on PCP and DT Act. Sir has always been conveying his best wishes to us. Unfortunately, he is not there in person, but sir has conveyed his best wishes for us. Our guest of honor for today are Dr. Usha Saraya, ma'am. We all know, ma'am, she's a consultant obstetrician gynecologist at Breach Candy, Saifi and Elizabeth Hospital. She's a founder, member, and past chair and past president of ICOG. She has started the cytology clinic way back in 1970, which has now become an internationally recognized center. Madam has been conferred with various national and international awards, few of which are Award of Living Legends, Honorary Fellowship by RCOG, Lifetime Achievement Awards. Madam has been the past president of MOGS FOGSI ICOG. We welcome Madam and request her to say a few words.
Thank you very much for that very kind and elaborate introduction. It really wasn't necessary because I'm a part and parcel of FOGSI for so many years, and I'm always happy to participate in your activities. Are you able to hear me?
Yes, requesting others to please mute themselves so that we don't have any disturbance. Thank you.
Okay. Thank you. So thank you very much for inviting me to this 7th episode of Clinical Pearls of JOGI. And I would like to begin by the statement that what is in the realm of research today will come into clinical practice tomorrow, because research has a far-reaching impact on humanity. As soon as we know something new has come, we begin to use it in our practice, and that is how we progress in our knowledge. So state of our knowledge is what it is today because of years and years of research done by our predecessors and research workers through centuries. Just imagine what was our knowledge of, say, endocrinology 100 years ago and what it is today. Who do we owe it to? It's to the people who have worked and reported and published their data. So FOGSians are really very fortunate to have JOGI, our publication of research papers, coming to us regularly without any failures and keeping us very well informed. And I'd like to thank all of them, especially the editors, and the current enthusiastic editor is Dr. Madhuri Patel, one of my favorite students from the days of Grant Medical College teaching, and all the FOGSI and the journal office bearers who devote so much of their very valuable time to this very enriching activity. Actually, it's a great thrill when your first paper or first article is published. It really gives you so much excitement and joy. My first article in JOGI was published way back in 1964 when I was still a resident in Kama Hospital. And I had no idea about all this. And I was asked by Dr. Girard to read a paper, and she said, now we're going to publish it. And to me, that's the greatest thing that ever happened to me. Dr. Girard and Dr. Masani used to attend all those student seminars and PG students and give us so much encouragement to write. So I feel all of you will remember always what you have written, and all the new people who are here today should realize that it's one of the joys of life, you can say, of your academic career. So I hope all the young doctors, more of them in their busy schedule, take to some research activity, collect data, learn how to do referencing, and eventually write papers. And by the time you progress little further and you have to write your biodata, you will realize how much importance is given to your publications. Anyone with good list of publications is always a preferred candidate for anything. So I'm also happy that JOGI has also progressed a lot. I've been watching JOGI and publishing in JOGI for years now, and it is holding two very important activities. And one, as Madhuri just explained to you, is the webinars and seminars on research methodology to help the youngsters understand what is good quality research and how to guide them. And that certainly is a great inspiration. And finally, also giving awards. And I feel that giving awards has also improved the quality of our publications, and we see what the good papers are and we give them due credit. And now this Madhuri's idea of having a pearl of wisdoms is even more important. And I think that will also encourage this activity. So motivation and inspirations are required even now when the students have so much other work to do, they do not get time to do this. So today's awards are going to these new speakers. We are going to listen to them. So let me congratulate them on the opportunity given by JOGI. And we would like to hear their presentations, and I'm sure it will inspire and motivate all of us also to continue with the work. So thank you all once again and for inviting me and making me a part of this group of discussion. And I look forward to the papers that will be presented. Thank you.
Thank you, madam. Thank you, madam, for your nice words. And thank you for sparing time for JOGI and us. Thank you once again. And if possible, madam, please stay back till, all the presentation.
Yeah.
So thank you so much, madam. Your words are really inspiring for the entire team of JOGI. I now have the pleasure of inviting our next guest of honor, Dr. Suchitra Pandit, madam. So, madam is a consultant, Department of OBGYN at Surya Group of Hospitals. Madam has been the chair of AICC RCOG, President ISOPA, President
Pradnya, it's okay. We'll start.
Justice India Association, President FOGSI, and I. Welcome, ma'am. So, I request you to please share some pearls of wisdom with our team, ma'am.
Respected Dr. Usha Saraiya, Gupta sir, Madhuri Patel, Pradnya, and the rest of the JOGI staff. First of all, thank you very much for having me over for this wonderful session on clinical pearls of JOGI. And as Madam said, it's a great opportunity to be here because ultimately it's research that propagates the progress. And if JOGI has created a forum where the research, the fellows or the people who've done their research can actually talk about their ideas and their results and get a feedback from others, I think that there can be nothing as good as that. And what is very nice is, now people are getting more and more aware. I remember many years ago, 96, 97, I'd come back from UK and I had done work on hormone replacement therapy at Sion. And I got the first prize for the FOGSI Courier Award. And many people ask me, but where did you get this idea from? I said, no, idea about research comes from when you want to do something new. And that time, we used to follow the BJOJ because I worked in UK. And the BJOJ had a system for following everything. And then they said, oh, but then don't you think we should all follow it? I said, yeah, I think all of us. And I'm so happy that now all the medical colleges also have started that initiative. Even the theses are reviewed, and you have a sample size, you decide how to go, what methodology to go. And I must thank Dr. M.N. Parikh also because he started the PICSEC workshops, which have taken on so well. And all the editors, I mean, including Madhuri, now they have propagated that and evolved and done something more. So I think it's a wonderful work that JOGI is doing. Apart from publishing that journal, they're also giving an opportunity for people of all ages to present their work and for that work to be read by others. It's only when we share our knowledge can we get much more better. And things have changed in the last 50 years. Even our practices have changed. That is because now we have so much more newer things coming out of the research. So Madhuri, once again, all the best for your your further programs. And I know you've got very systematically planned out programs, and I've attended 3 or 4 of them already. But great, Pradnya, thank you for inviting me and looking forward to hear all the 3 papers. And I'm, once again, very, very grateful that Dr. Usha Saraiya and Dr. Sanjay Gupte, both my mentors who actually pushed me into FOGSI and got me into the realm of things. I'm so glad that both of them are here today. Thank you so much.
Thank you, Suchitra, for accepting our invitation and sparing the valuable time with us. And I must talk about Dr. Suchitra. She was also Joint Secretary to, if I remember, to Madam Saraiya. And Sanjay sir is always our guide. And Suchitra, I must say that since we started PICSEC program and all these webinars, we are getting such a good articles. As I said, our rejection rate is, since we are getting more than 1100, 1200 articles and we have to take only 110, it becomes very difficult to reject. So our rejection rate is almost 85%. And I'm telling you, after this PICSEC program, whatever we say, our teachers, research methodology, we are getting such a good article that becomes very difficult to reject. But we have to do it. So I'm very happy that these programs are going on very well. And juniors are, into the research methodology. That is a very great thing. And we will have more evidence practice in our, India also. So we are hoping for the same in the near future. Thank you very much.
So thank you so much. We now move ahead with the program. I request Dr. Sunil to introduce the guest of the chairpersons for the next session. Dr. Sunil?
Pragna, sir is here, he's going to present. So can we take his blessings also, sir?
Yes, sir. I request Dr. Gupte, sir, to please address the audience. Sir?
Sure. it's my pleasure to be here, and it's great that our team will be presenting, our genomic lab team will be presenting the today's presentation. It's so wonderful to see Dr. Saraiya, then my close friends Dr. Madhuri Patel and Suchitra Pandit. I think they are stars in FOGSI now, as Madam Saraiya is the icon of FOGSI. And then I can see Sujata, and sorry Sujata, I was pushed in. You are the chairperson. It's your
It's okay.
privilege.
That's
And,
okay. Doesn't matter.
and so it's really great to have, and all the youngsters, those two Pradnyas and Sunil, it's so nice to have these youngsters, actually conducting it, because this is the way I think Dr. Madhuri's idea is to take the journal and especially the selected articles to the actual our audience, and I think that's a very important step to connect to Foxians, because journal, frankly, many times people see, but actually whether they go through it or not, but this will make them definitely wake up and acknowledge the thing. For just couple of things about the presentation before I close, is that we do these newborn screening panels, and now it's possible that to do on cord blood and find out what that baby is going to have or any problem in future. And genetic panels are more in detail, and as many as 400 different conditions can be diagnosed. So my plea now is, we are many times our patients are collecting stem cells which are collected, we hardly ever use, they spend on it. And instead of that, if we shift on to newborn screening, then I think that will go a long way in actually getting the idea about what's happening to that baby, what's going to happen, and take precautions accordingly. And for Saraiya Madam, just one news, Madam, our team, Dr. Preeti and Dr. Sarjan, who are there today, they have developed a self-detecting kit for and validated for HPV and for all 14 high-risk factors. So I will have one of them meet you, because you are the person who should comment on it, appreciate it, and they will come to Mumbai, take your appointment, and discuss with you all. If you guide them, that will be wonderful. And again, Dr. Suchitra, Dr. Madhuri, you've been always guiding people, helping, being mentors to the youngsters. Is wonderful to see you. And I believe Dr. Jaideep has also joined, and I think his year is going wonderfully well. And I think Jaideep, again, a lot of all that material that you got and new projects you got for FOGSI is absolutely unbelievable. Thank you so much, all of you.
Thank you, sir. Thank you very much. Good evening, respected seniors, faculty, and dear delegates. Sir Isaac Newton once said, if you want to see further, it has to be standing on the shoulders of giants. So these are the principles we believe in and what we do at JOGI. Same thing is re-emphasized by Saraiya Madam, Madhuri Madam, Pandit, Dr. Pandit, as well as Gupta sir. I would like to introduce today's chairperson for the program. It's my privilege to introduce Dr. Sujata Darvi, Madam. She is senior obstetrician and gynecologist from city of Mumbai, affiliated with Global Hospitals.
It's okay.
Elizabeth. She is our joint.
Just say associate editor and that's it.
Yes, madam. She is our beloved associate editor of JOGI, currently treasurer at Emojis. We welcome you, madam.
Yeah.
Next chairperson.
So, no problem.
Next chair. I invite Professor Dr. Sampath Kumari, Madam. She is senior obstetrician and gynecologist. She is deputy director as well as professor at Institute of OBGYN MMC Chennai. She is FOGSI Vice President 2003. She is senior FOGSI member and has been active among various committees. Thank you, Madam. We welcome you, ma'am. Thank you. I invite Dr. A.G. Radhika, Madam. She is a senior obstetrician and gynecologist, having thorough interest into medical research and publications, a national coordinator for clinical research for FOGSI, She's our national editor at JOGI. And importantly, Geneva Foundation of Medical Research. She has been member of Cochrane Collaboration, South Asian Cochrane Network, Campbell Foundation, and needless to say, she's been having more than 75 publications, national, international, and credits, and she's a mentor to doctors like us. We welcome you, madam. I request chairpersons to introduce first speaker for today.
Yeah. Okay. So thank you, Sunil, for a nice introduction. At an outset, I would like to express my gratitude to FOGSI President Dr. Jaideep Tang and Editor-in-Chief Dr. Madhuri Patel for giving us an opportunity to participate in this program. I would also like to acknowledge the words of wisdom which have been given by our guest of honor, that is Dr. Usha Saraiya and of course Dr. Suchitra Pandit. So at an outset, I would like to introduce Dr. Sanjay Gupte. He is a past president of FOGSI. It's my proud privilege to introduce him. Currently, he is a FIGO's Ethics Committee chairperson. He's also been awarded FRCOG honorarium by RCOG London. He's been a president of DIPSI, Secretary General of World Justice Organization. He's been a chairman of Technical Research Committee of ICMR, and he's been a national little bit more. He's been a national coordinator of National Eclampsia Registry, and currently he's a director of Gupta Hospital and Center, and also he's a director of.
Sujata, let's take the program.
No. The important thing, the green array genetic research. That's where the paper is coming from, and I would like to invite Dr. Sanjay Gupta and his team to speak. Today, they are going to present a case report on newborn genetic screening, which is significance in early diagnosis of an infant with mitochondrial DNA duplication syndrome 6. And he's already explained how important it is to have the cord blood, which has been collected, and how it is useful to make a diagnosis of some metabolic syndrome so far as the neonates are concerned. So over to Dr. Sanjay Gupta and his team.
Very good afternoon, all. I am Dr. Preeti Arora, Chief Genomic Scientist at Green Array Genomic Research and Solution. So today I am going to present that case report. So I am sharing my screen. My phone. So my screen is visible.
Yes.
Yes, ma'am.
Yeah. Thank you. So today I am going to present a case report published in the Journal of Obstetrics and Gynecology of India on newborn genetic screening, significance in early diagnosis of an infant with mitochondrial DNA depletion syndrome 6. So before moving ahead, a small introduction. Yeah. So introduction to newborn genetic screening. So as we know that newborn screening refers to the practice of testing newborn for serious and life-threatening genetic, metabolic and hormonal conditions. It has various benefits. First and the most important is it can early detect conditions before any clinical symptoms appear, which enables early treatment to prevent severe consequences like developmental delay, disabilities, or even death. It has a major impact on health. It can significantly improve prognosis for rare genetic disorder that may not be detected through traditional methods. Actually, my screen is not moving. I'll stop share and again share.
Click on the slide.
Yeah, I'll just.
Dr. Preeti, I can share if you want. Go ahead. Yeah.
So now for the newborn screening, evolution from biochemical to genetic. So as we know that traditional biochemical screening initially focused on detecting a few of the metabolic disorder like PKU, hypothyroidism, and cystic fibrosis. So it basically measures the enzyme level or some of the hormone deficiency. So any sample which comes out to be positive in this traditional biochemical screening needs to be reconfirmed again with a second sample and eventually with a genetic test, either by next generation sequencing or the Sanger sequencing. So as we know that every technique has certain limitations and advantages, it is very important to know the limitations and advantages of all the techniques. So the limitation associated with that, it is important to adhere to the recommended time frame because the cutoff value basically for this screening value is for screening analyte and set for to reflect some of the values expected at this age range. So there may be chances of false positive results due to in case of some preterm babies, and also false negative in case of we can say one of the disorder galactosemia, in which generally the GALT enzyme or the final metabolite, that is galactose, is measured in this biochemical screening, and it is very important how the sample is collected and how it is stored and how it is shipped to the laboratory, because this GALT enzyme is very much sensitive to heat. If it is exposed to high temperature, there are chances of false positive and false negative result. Now, coming into the newborn genetic screening, it basically utilizes next generation sequencing, and it can screen a large number of genetic disorder. It can identify even a single gene disorder. Some of the mitochondrial DNA defects also we can cover here, and the other conditions that biochemical screening cannot detect. So now coming into the case that we have done and analyzed and published. So here it is a case, 35-year-old female, consanguineous marriage was there, presented at 20 weeks of gestation with abnormal ultrasound finding, which is indicative of fetal growth restriction and fetoplacental insufficiency. Now looking into the obstetric history, there was a 2 miscarriage, one intrauterine death at 8 months of gestation, one neonatal death at 2.5 months of age, but that was suspected of some of the metabolic, because of metabolic disorder. This child had clinical sign including hepatosplenomegaly, renal failure, ascites, but there was no significant diagnosis was made. So, looking into the advanced maternal age, there is an increased risk of a complication. Looking into consanguinity, there is an increased risk of autosomal recessive disorder. There was a huge pregnancy complication was associated. There was 2 recurrent miscarriage, one IUD at 8 months, one neonatal death at 2.5 months of age. And the recent pregnancy, there was an abnormal ultrasound finding. So, considering her ultrasound abnormality and advanced maternal age, during pregnancy, a non-invasive prenatal screening test was referred, and this NIPS result indicated low risk for common chromosomal aneuploidy such as trisomy 21, 18, and 13, and no chromosomal abnormalities detected that would explain the ultrasound findings of previous neonatal death. So the outcome was the patient delivered a healthy female child without any clinical sign of genetic or metabolic condition at birth. Then, due to a history of suspected metabolic disorder in the previous child and unexplained neonatal death, the newborn was referred for newborn genetic screening immediately after birth. Now the question arises, there can be a short newborn genetic screening panel or the extended panel. So in the short newborn genetic screening panel, generally 47 genes are included, which are covering around 38 congenital genetic disorder. And in this metabolic disorders, hemoglobin disorders, congenital hearing loss, and endocrine disorders are covered. So this short gene panel are generally recommended for routine screening, or if any has a known history of any genetic condition. In the extended panel, apart from this, there are some mitochondrial nuclear gene disorder, hemoglobin disorder, epilepsy, immunodeficiency, neuromuscular disorder, some of the pediatric cancer, genes associated with vision loss, renal disorder, and congenital heart defects gene are also included. So looking into the clinical history, since the previous child, there was a neonatal death suspected of metabolic disorder, but not the actual diagnosis was made. So the testing that was performed was newborn genetic screening, that is extended panel, not the routine short gene panel. So here's are the result. A homozygous pathogenic variant in the MPV17 gene was detected. So any variant which are detected on NJS always need to be reconfirmed with Sanger sequencing. Though we know that the sensitivity of NGS is very high, but when we have to correlate that variant with some disease, then it has to be reconfirmed with Sanger sequencing. So after the NGS, whatever pathogenic variant was identified, it was reconfirmed with Sanger sequencing, and the same homozygous pathogenic variant in the MVP gene was detected. Now, these are some of the genetic findings. This MPV17 gene basically encodes a mitochondrial inner membrane protein that is very much crucial for mtDNA, mitochondrial DNA maintenance. So mutation in this gene lead to mitochondrial DNA depletion syndrome. So the couple consanguineous relationship likely contributed to the inheritance of this autosomal recessive disorder. Now, what is mitochondrial DNA maintenance defect? So now coming into the mitochondrial disorder can occur either because of mutation in the mitochondrial DNA or mutation in the nuclear DNA. So when mutation occur in the nuclear DNA, it may affect the factor needed for mitochondrial DNA replication. And when this replication is hampered, there is a significant reduction in the empty mitochondrial DNA copy number that lead to energy failure in affected organ. And affected system involve liver, muscle, and the neurological system due to high energy demand. And the major gene which are associated with this disorder are MPV17, POLG, and TK2 mutations. Now coming into the MPV17 gene specifically, which was detected in this case, and mitochondrial DNA depletion syndrome. So this MPV17 is basically a mitochondrial inner membrane protein. It is located in the inner membrane of mitochondria. Here we can see that it forms a specific channel, and this channel ensures the proper balance of nucleotides that is needed for mtDNA synthesis and replication. So this homozygous mutation that was identified in this MPV17, it hampers its function, as a result of which the proper deoxyribonucleotide may not enter inside the mitochondria, which hampers its replication and it causing the mtDNA depletion. So clinical manifestation, progressive liver failure, metabolic impairment, fatal outcome without intervention, typically within the first year of life. So now coming again into the case, the parents were informed for the genetic finding and the implication of the MPV17 mutation, advice about the risk of the child developing mitochondrial DNA depletion syndrome. So in the follow-up plan, a regular follow-up with a pediatrician was there, and close monitoring of the newborn for sign of mitochondrial dysfunction. So after 2 months, the infant presented with failure to thrive during a routine medical checkup. Physical examination revealed enlarged liver suspected. So they went for a biochemical finding in which they have done the liver function test and amino acid analysis. So here we can see all the liver function tests showed a deranged liver enzyme indicative of liver impairment, and also the amino acid analysis, there was a moderate elevation of alanine suggestive of lactic acidosis and elevated histidine and other amino acid likely due to liver dysfunction. So the clinical diagnosis was confirmed that the baby is diagnosed with mitochondrial DNA depletion syndrome. So now in the management plan, the infant is receiving symptomatic medical care. In future plan, a liver transplant may be considered as the next step. So in this mitochondrial DNA depletion syndrome, there is a symptomatic treatment. The therapies that are available is liver transplantation. In case of prognosis, it remains a challenging disorder because there is no definite cure. But early diagnosis through newborn genetic screening has allowed for monitoring and symptom management. But long-term prognosis depend on the progression of liver disease and other systemic complications. So to summarize, newborn genetic screening can detect a rare genetic condition that may not be covered in a traditional biochemical screening. And genetic counseling, of course, plays a very vital role in guiding families and ensuring informed decision making regarding medical interventions. Thank you.
Yeah. So thank you, Dr. Preeti. That was an excellent case presentation. I just have one or two practical questions that I would like to ask you. One is this: you did genetic screening, you collected newborn's blood on first 24 hours after birth or first 48 hours. That's number one. And how much of a blood do you collect it so far as a newborn is concerned? Like, how many cc's or whatever it is, it could be necessary. All you could let.
Yeah. So, ma'am, in this case, it's a genetic screening. So, time frame or time window is will not change any of the result. Whatever
Okay,
variant
fine.
is present,
Yeah.
it is present.
Huh.
And analysis we have done on cord blood. Since we
Okay.
have validated and optimized our panel on cord blood also, and even the heel prick. So, we have done this analysis or this case on cord blood sample.
Okay, so that is what I wanted to ask. If at all you find patients with this obstetric history like this, we can already counsel the parents and then we can collect the cord blood so it becomes easier for the genetic lab to process the whole thing, correct?
Yes, yes.
And cord blood has to be collected plain or in some EDT or whatever it may be? Or is it collected like how we do it for stem cell preserving? Is it something of that sort?
No, ma'am. Simple EDTA blood we need. And only 1 ml is fine for us. We do.
1 ml is good for her.
Yes.
And how many days does it take to get the reports?
It will take, ma'am, 10 days, 10 to 12 days to get
10 to 12 days for them to get the report. So we can discharge the patient and ask them to follow, correct?
Yes, yes, yes.
Okay, okay. Thank you so
I
much.
have a question.
Yeah.
Can I ask? See,
Yeah,
when
yeah,
you're saying that you
definitely.
can take cord blood, but cord blood, isn't there always that concern of admixing with the maternal blood? So sometimes you may not get absolutely correct reports, Preeti.
Actually, ma'am, we have validated this on the cord blood. Initially, we also thought and we came up with most of the research article, there is a chance of 0.001% that it may
Yeah.
get contaminated with the maternal blood. So before starting actually on the cord blood, we have taken cord blood sample and also the heel prick sample. We have validated the complete panel on more than 50 to 100 newborn, and then we have started this after checking that all the variants, whatever we are detecting is same and there is no extra variant or a maternal contamination is there.
Okay.
But now, one more question, Preeti. Nowadays, there is a tendency to screen most of the newborns with some metabolic syndrome. Of course, at that time, they don't take the cord blood. So how is it different from what you have been doing it? Yours is, of course, an extended because patient had a bad obstetric history. But when they do the routine metabolic syndrome, is it something different or anything?
Yes, ma'am. So we have designed two different panels. One is newborn screening short panel in which we are covering all the metabolic disorder that are already covered in a biochemical testing like biotinidase, G6PD and everything we are covering. In an extended panel, when there is some history, then we can go for extended. Otherwise, we can go for a routine screening, a short panel, short gene.
Okay, so in routine screening also cord blood is good enough or you need to prick the newborn and get it done?
No, ma'am. Cord
blood is good enough, no? Yes. Okay, fine. Okay, thank you so much, Preeti.
Welcome.
Madam Saraya.
Thank you, doctor. Yeah.
Madam Saraya. Any comments, madam? Yeah, unmute. Madam, you have to unmute. Madam, you have to unmute. Madam, you have to unmute.
Madhuri, nowadays, most of the high-end centers are collecting cord blood and they're sending it not only for metabolic, for rest of the things also. So there are few centers who are already doing this,
Yes.
Not the extended one, but the simple one.
Simple one, yes.
That's what. And they collect cord blood. When we collect the cord blood, they do everything. Blood group and thyroid and G6PD along with this metabolic syndrome also, but not all centers. Madhuri?
Our major hospitals are doing like
yes, the high-end hospitals, they are doing that, Madhuri. So that's why I just wanted to reconfirm. That's all, nothing else.
Yes.
Yeah, Dr. Saraya, still she needs to unmute.
Madam, you unmute, madam.
I think she can take help.
She has muted me from
now she is unmuted if I'm not mistaken.
No,
Yes, madam.
what I was interested in commenting is that they said the possibility of a liver transplant for this baby, will it be the end of the problem, or will the baby be able to live properly with a liver transplant alone, or will have still some problems? And the other thing is that recently in Pune they have done liver transplant for newborns or young, in you can say pediatric liver transplant has already started in the city of Pune. We know because one of our friends has a family who is into this pediatric work. So I'm sure Sanjay would know about it. So there is some future to doing all this, because what is the prognosis even after liver transplant or without it? Is there a lifespan? You can say how long the child will live?
No, ma'am, actually it depends how, because sometimes when there is a genetic variant or a disease, its penetrance and the type of symptoms will also vary. So these are the two treatment available for mitochondrial depletion syndrome. But for the prognosis, we cannot comment on that.
It's a guarded prognosis for life for the child.
Yeah. Can I say one word for liver transplant, ma'am? Now, pediatric and even newborn liver transplant is being done even in Mumbai, city of Mumbai, and they've got good results also, madam. Like Glen Eagles, they've started with that, and they've got good results so far as liver transplant is concerned.
Yes, so liver transplant is a possibility.
Yes,
but if
madam,
the long-term
and with
prognosis is
good
not
outcome, with good
then
outcome. Yes, madam.
long-term prognosis has to be good, no? Yeah.
That we have to wait and see.
At least liver transplant is available.
Yes, madam. It is available.
Dr. Sampath, your comments as a chairperson?
Yes, I was want to congratulate Dr. Preeti. That's all. Last madam was telling some centers are doing, but till this metabolic problem, everything is. We will see the prognosis. It's a wonderful presentation, Dr. Preeti, under Dr. Sanjay Gupta, sir.
Thank you. Thank you.
Dr. Preeti, you presented so well, and we are into it that we can go for the genetic, taste. Previously, we were with the biochemical, now we are doing with the genetics. I wanted to know that in short, gene panel, you have 47, and in the long one, you have more than 400. So how this, things you decide, it was decided, okay, we should have this gene and that genes, how it has been decided?
So ma'am, in the short gene panel, looking into the Indian scenario, what all the disorders are prominent and need to be screened immediately, we have included. So that can become under a routine screening. Or suppose if a case come with having a baby with G6PD. So we are covering complete gene of G6PD biotitinase, then we can go for a NBS short panel. But if the suspected child or a previous child, or there is a history of some of the metabolic disorder, but the diagnosis is not confirmed, in that case, we can go for an extended gene panel where we are covering a large variety of disorder, more than 400. So depending on the case, we decide whether to go for a short gene panel or an extended gene panel.
Excellent. I must say that, newborn screening, when baby, if she was pregnant, the baby was as a fetus, we could not screen, but newborn screening, should be done for each and every baby when they can afford. So at least we can't prevent, but at least we can do the symptomatic treatment, and we can make it a prognosis better and better. As Madam Saray has pointed out, the liver transplant is really successful, and we have to see prognosis that will come after many years, because as madam has already mentioned, that research and you get the result after many years. So this is the a case presentation. I am really congratulate you and sir and your team. That is an eye opener for many of our obstetrician and gynecologists, that they should not neglect of screening the babies newborn when they can afford it. So we get the ideas that everything is fine, but if everything is not fine, then they are counseled, they are told what to do and what not to do. So it will definitely give good prognosis to the baby. We cannot prevent, but at least the prognosis will be good. So once again, congratulations to Dr. Sanjay Gupta sir, Preeti, and their team. Thank you very much for coming and showing your work. Over to you, Chairperson Sujata.
Yes, madam. Good
I
evening.
think Dr. Sampath Kumari will introduce.
Yes, madam. Yes, Sujata. Good evening to all. I should thank Dr. Jaideep Tang sir and Madhuri madam, the editor, for giving us this opportunity for chairing the session with Dr. Sujata and Dr. Radhika madam. Good evening, Dr. Sanjay Gupta sir and Dr. Sunil for wonderfully moderating the entire program. Yes, now we go with that next case discussion, that is with the transrectal ultrasound for cervical cancer by Dr. Veera. She is the consultant radiologist with a subspecialty in breast and gynecological imaging and subspecialty training in women imaging conducted by the Columbia Asia Radiology Group in 2018. He is the HOD of Radiology Department in Siloam Hospital, Kibon Jerk, lecturer and preceptor in Medical Faculty of Universitas in Pelita, Harapan, speaker in multiple national conferences regarding women aging, multiple awards and honors in national symposium and conferences. The stage is yours. You can present, Doctor.
Good evening to dear professors and colleagues. My name is Farah. Thank you for inviting me here. And I'm honored to present my paper, which has been recently published in the Journal of Obstetrics and Gynecology of India, entitled Transrectal Ultrasound in Cervical Cancer, a systematic review of its current application. As we are all aware, cervical cancer is the fourth most common cancer in women, and the incidence keeps rising from 570,000 new cases in 2018 to 660,000 new cases in 2024. However, as we can see in figure, the incidence is the highest in low and middle income countries such as Africa, parts of South America, and Indonesia. In Indonesia, it is currently the second highest cancer in women and contributes to one of the highest financial burden. Some contributing factor may be inequality in FFF vaccination. Mass vaccination only started in 2016. The trend for mortality is the same as for the incidence with 350,000 deaths in 2022. Again, as we can see, the figure cervical cancer was the leading cause of cycle-related death in LMIC, particularly women in Eastern, Western, Middle, and Southern Africa. The highest incidence was estimated in Eswatini with approximately 6.5% of women developing cervical cancer before age 75 years. China and India together contributed more than a third of the global cervical burden with 106,000 cases in China and 97,000 cases in India and 48,000 deaths in China and 60,000 deaths in India. The International Federation of Gynecology and Obstetrics continue to recommend clinical staging till 2009 with only a few basic investigations allowed to change the stage. The recommendation for clinical staging is based upon the fact that LMIC may not have access to MRI, which will be difficult to practitioners. There are two-stage cervical cancer without MRI. There are different imaging methods for gynecology oncology, as we can see in this table, where ultrasound allows dynamic evaluation with no radiation, exposure, and limitation. Ultrasound may not be readily available, but it is certainly more feasible for LMIC to obtain ultrasound as compared to MRI and FDG PET-CT. And in the newest guideline of 2023, ISGO, ISTRO, ESP, ultrasound can be used as an alternative to pelvic MRI to locoregional staging for cervical cancer. Ultrasound is an option for staging in specialized centers with trained sonographers using all approach transvaginal, transrectal, perineal, transcutaneous, and transabdominal as appropriate. There are 4 ultrasound approaches for gynecologic cancer staging: transvaginal and transperineal in combination with transrectal approach for local staging. Transabdominal approach using a convex and array probe for evaluation of abdominal infiltrated visceral and retroperitoneal lymph nodes, peritoneal or parenchymal metastasis. Transcutaneous approach with linear array probe for evaluation of inguinofemoral lymph nodes. I could not cover all the theories on transrectal ultrasound, but the citation that I mentioned in this slide from Visikoverova is a great source. Transrectal insertion of the probe has an advantage in patients who are virgo-intacto, have a stenotic vagina, or have undergone brachytherapy, in whom transvaginal insertion is not possible. However, the main use of transrectal approach is for the detection of locally advanced tumor of the vulva as well as early and advanced vaginal and cervical cancer. In this case, the transrectally inserted probe allows for the detection of tumors spread into the paracopium, parametrium, and vesicocervical, vesicovaginal, and rectovaginal spaces, and the urinary bladder and rectum. Yes, this is the transrectal scan from a patient with complete rejection of large cervical tumor, stage 2B after combined radiotherapy. Note this appearance of hyperechogenic line corresponding to visceral fascia of the bladder and cervix. The previously inflated fascia have retracted and became fibrotic due to radiotherapy, yellow cycle. While transabdominal and transvaginal routes has been described extensively in cervical cancer, truth has been more heavily with prostate, bladder, and anal cancer. When transrectal ultrasound is mentioned, they are mentioned in tandem with other ultrasound routes, making truth seems like a complementary route and not a primary one. Therefore, this systematic review aims to aggregate and describe the current use and advancement of truth in the medical literature in hopes of identifying where the literature is currently lacking. Hopefully, it will help clinicians, researchers, and other stakeholders to develop more robust studies of truth in cervical cancer. We can't delineate of our methods here, but those who are interested can access the full paper or our protocol on the Prospero database. The population studied are all cervical cancer patients who were confirmed by histopathological analysis, and truth was used as either a diagnostic method or as an adjunct to therapeutic procedures. The exclusion criteria include studies that only mention truth in the manuscript but did not mention any result regarding truth would be excluded. Studies that combine the use of truth with another route of ultrasound, such as transabdominal or transvaginal, and presented the result as one. Those studies will also be excluded. Studies with less than 10 patients enrolled will also be excluded. Displayed in this slide is the Prisma flowchart with such 5 databases, and after removing the duplicates, there are 3,330 articles that we screen. After assessing the eligibility of each article, there are 31 articles included this systematic review. For those who you are familiar with this topic, some of you may feel that there are more than 31 articles of truth for cervical cancer, and you are right. However, most studies are excluded since they are not specific toward cervical cancer, not specific toward truth, or sample size is less than 10. In this review, there are 635 poor women with a mean age 52.9 years old. Most studies employ prospective methods with only 10 articles out of 31 had a fair rating. Most studies enroll squamous cell carcinoma with FIGO 2B staging. There are 181 patients with reported complication from TRUS, with 106 women reporting pain, 59 women with hemorrhage, and 10 women with perforation. However, it is to be noted that most studies did not report the complication rate. According to our research, there are 7 categories TRUS used, which are 1. Assessment of cancer extension, operative assessment, diagnosis, assessment of chemotherapy and or radiotherapy, staging of cervical cancer, intraoperative guided procedure, and brachytherapy. The first one is assessment of cancer extension. There are 3 studies with 266 women enrolled with a mean age of 49.9 years old, mostly FIGO 2B staging. This study found that TRUS correlated strongly with MRI, but TRUS has a lower sensitivity than MRI. TRUS has a high sensitivity, negative predictive value, and predictive accuracy in assessing parameter invasion of uterine cervical cancer. This second one is preoperative assessment. Only one study with poor quality. The study found the accuracy rates were 90.5% for the left cardinal ligament, 85.7% for the right ligament, and 81% for both ligaments. Conclusion: TRUS may be useful in preoperative assessment of cardinal ligament vessels. The third one, for diagnosis, there are 2 studies with 41 women enrolled with a mean age of 51.8 years old. The studies found that TRUS is a sensitive method in evaluating cervical cancer mass as well as its measurement. TRUS guided biopsies could provide adequate material for histological diagnosis without any procedure-related complication. The fourth one is for assessment of chemotherapy or radiotherapy. There are 3 studies with 113 women enrolled, mostly SCC with a FOGSI 2B staging. There is a conflicting result where 2 studies agree that TRUS is comparable to MR to comparing the maximum target width and thickness in evaluating the accuracy and locally advanced cervical cancer after chemotherapy. One study found that TRUS and MR together with clinical examination only agree 30% of the time. They further state that MRI staging correlates better with outcome than with TRUS or clinical examination under anesthesia. The fifth one is for staging. There are 7 studies with 610 women enrolled, the most among any other. The mean age is 54.1 years old, mostly SCC with FIGO 1B staging. The results show the accuracy of TRUS for the staging of cervical cancer or evaluation of tumor volume range from 75 to 75% when compared to MR or clinical examination. Other studies demonstrate that tumor size as measured by TRUS may predict relapse or show consistency with histopathology in the staging of cervical cancer. There is no statistical significance between TRUS and MR in judging the gross tumor volume, which highlights the potential of TRUS in clinical setting. The sixth one is intraoperative guided procedure. Only one study with poor quality, 25 women, 24 to 84 years old. Thus allow delineation of external cervical os during dilatation and curettage, which is helpful in selected patients in whom the cervix is malformed or shortened iatrogenically by prior conication. The seventh one is for brachytherapy. There are 13 studies, the most studies in this systematic review with 559 women enrolled. The mean age is 52.7 years old, mostly SCC with FIGOs 1B staging. The results show inter-observer ICC values of TRUS as comparable with MRI for FOGSI and 2 for higher clinical target volume, but not with larger tumor. TRUS help in accurate placement of needle, thus avoiding the injury to normal pelvic structures. 4 studies received a poor rating. 1 cannot be assessed as it only an abstract. The rest received a fair rating. The lack of consistency guideline in TRUS is depicted in FIGO 2021 and ISGO ESP 2023 guidelines, where TRUS is only mentioned once in FIGO 2021 and 3 times in ISGO 2023. TRUS is due to the risk of trauma of normal structure like the bowel and bladder. Use of ultrasound imaging, especially transrectal, is suggested during the implant procedure. The only consistent recommendation between these 2 guidelines is the use of TRUS for brachytherapy related purposes. The use of TRUS in brachytherapy has progressed significantly. In 2012, the American Brachytherapy Society consensus guideline recommended all TRUS to help guide intracavity applicator to best visualize the pelvic anatomy and reduce perforation rates. However, this is only mention of TRUS among the 2-part consensus guidelines. Recently, the Indian Brachytherapy Society, the group European the Uretherapy, and the European Society for Radiotherapy and Oncology, and the American Brachytherapy Society published a new guideline regarding CT-based contouring in image-guided adaptive brachytherapy for cervical cancer. Especially in this guideline mentioned that TRUS has been utilized to identify a specific target structure relative to the cervical canal during brachytherapy. The transrectal approach is favored over transvaginal probe insertion when dealing with a bulky tumor. This choice reduces the risk of bleeding for the tumor exophytic portion and allows for a more accurate examination of the distal part of the cervix. The transrectal approach also circumvents challenge posed by artifacts caused by tumor bleeding, necrotic tissue, and probe tumor contact. However, this review found that most cancers belong to 2B and 1B stage, which means the tumor are below 4 cm in the largest size. Tumor with large size may be mistaken as a parameter infection, falsely elevating the FIGO staging. Implementing TRUS entails a learning curve, and yet most studies do not mention who performed the TRUS. However, the learning curve for doing TRUS may not be that steep. Those who did vaguely mention that the study was performed by 1 or 2 examiners. When TRUS is done by examiner who is not an expert, there may be some variability introduced in image acquisition and interpretation. The ISGO ESP 2023 guideline also specifically mentioned that TRUS need to be performed by a properly trained sonographer. Limitation. Stringent inclusion and exclusion criteria. There is a lot of literature where they claim the use TRUS in the methodology, but either present only 1 to 5 patients using TRUS. Most studies have poor quality according to the NOS criteria. The third limitation is the most studies included a low sample size. Most studies recruited less than 100 patients. Fourth, there are 4 editions of FIGO, namely in 1958, 1971, 1985, and 2018. Therefore, there may be some variability in the staging presented in this review. Lastly, this review cannot account for publication bias and heterogeneity, as a clinical practice still vary among centers and studies. Conclusion, the recommended use of TRUS is still limited in formal guidelines, while clinical research still lacks. The review's 2018 FIGO staging already allow the use of any imaging modality and or pathologic finding for allocating the cervical cancer stage. However, the use of TRUS has been lagging as compared to TAUS and TVUS. Limited imaging modality in LMIC means that optimizing the route of ultrasound may be helpful for the operator to diagnose, follow up, and treat cervical cancer more effectively and efficiently. Thank you.
Good evening, doctor. It is a very nice presentation.
Thank you.
Now, I want to know this, you are restricting only to one stage and second stage. In third stage for the lymph node involvement, how are you proceeding? Are you combining this with MRI or only transrectal?
Yeah, and this review article, the research also that MR for comparing the ultrasound results. They done all imaging.
No, so if a mass is more than 4 centimeter means we are not going to do the vaginal. In that case, we go with
Actually,
yes.
at the first, they want to do for the big mass, more than 4 centimeter. But in the practically, the tumor is less than 4 centimeter in this review article.
No. My question is, you are doing only with the transrectal or combining with MRI. Will there be any difference in the staging if you do only with the transrectal?
No, this is combining with MRI.
Okay.
He's saying it is combined with MRI.
Yes. Then if you are doing MRI means why you want to do this transrectal?
Yeah, because Indonesia is middle low income country, and the MR or CT scan is not distribute in the peripheral region. That's why we think this is interesting to use transrectal ultrasound as a good modality to give a staging for cervical cancer. If the peripheral area doesn't have MRI. Indonesia is a big country, but MR is just in the central, in big city. There's no MRI in peripheral area. That's why we think this is an interesting modality. Better than nothing.
See, in a cervical growth, the mass will be obviously seen. Why you want this transrectal ultrasound for taking biopsy?
Yes.
Yeah. Can I say something
Yes,
about
madam.
it?
Yes, madam.
So, this is a very common problem we have of not having the MRI facility.
Yes.
And the treatment is getting delayed because we don't have this imaging. Because Frigo says imaging is necessary before you plan the treatment.
Classic.
So an ultrasound is freely available in most, at least OB/GYN units, because of obstetric use. And we have radiologists who are very well trained to do this ultrasound. And as this author has said, you do transrectal, you do abdominal, you can do it from the perineum, and you get lot of information which is enough for you to decide what is the plan of treatment. Then after that, if it is to be doubtful, it has to be referred to an MRI, or you can give some pre-op chemotherapy we are giving immediate, so that at least the growth is stopped. We are giving antibiotics, we are improving anemia. There's so many factors which the patient has to have. So this knowledge of trust is very important, and we should have more radiologists who are ultrasonologists, as they call themselves. They should be trained in this, because they otherwise they are not taken seriously. People say just go for MRI, and MRI may take 3 weeks appointment, or it may not be within the budget of the patient.
Yeah.
But she is telling the transrectal and MRI. combined. That is the reason I want to convey. Okay, madam. Thank you. Any other questions?
Dr. Radhika?
Yeah, a very good afternoon to everybody. Thank you, Dr. Madhuri. So I must congratulate Dr. Vera. That was a nice presentation. So there are two aspects to this presentation. So one is the fact, the topic as such, and the utility, the translational value, as Dr. Sampath has been asking you, the translational value of your presentation. That's number one. So like you have been, during the course of your presentation told us for each of those objectives that you had to identify in your systematic review, that there have been studies. However, they were limited by their sample size. Okay, so it's not, people have been thinking about it, and there are many studies which are available. However, the number of people recruited are few, which is generally the case for malignancies, because it's not possible to have a big sample size. So for a diagnostic modality, the method of a secondary research changes. Right. So since you are undertaking a secondary research by way of a systematic review. So there are two aspects to this presentation, I feel. So number one is a translational value of trust. So that has been, well discussed just now. But I would also like to comment on the systematic review, that you had detailed. So I just missed the first few slides, but I just wish to understand, because the databases that you showed were just a handful. So the difference between a systematic review and a primary review is that you cast a large net. You will cast a huge net into the ocean so that you catch as many fish as possible, the small and the big ones. So if you restrict yourself to the English literature and have only 4 or 5
Radhika, you have to.
Yeah. So I think the host muted me. So so you need to have more databases, okay, and for us to find more studies. Indian authors have traditionally been having a huge limitation in the sense that we do not have access to EBSCO and Scopus and those kind of. So PubMed is something that's easily available. But I would have also appreciated if you had talked about the Cochrane database, if they had, also had such systematic reviews, because given the fact that ultrasound has been there in this field for a long time, it would have been also a good idea for us to look for any other systematic reviews that have been, published earlier, and compare the outcomes of yours, because what I found was majority of your objectives, the conclusions were limited by the poor quality study. So your recommendations would all be conditional, right? So so if you were to think of developing a guideline after this systematic review, again we are limited by the quality of the systematic review. It's like you put good vegetables, you get good curry. So the methodological aspect of your systematic review has to be robust. And it has to be so robust that the keywords have to be presented so that if somebody else were to repeat it, they would get the same results. So the problem with Google Scholar is it is not reproducible, and that is why it is taken as a gray literature. And therefore, it is very, very important for us to have the standard databases to conduct a systematic review with reproducible, transparent keywords, which are actually separate for each of the database. And that's why systematic review takes a little time. This systematic review, I can understand meta-analysis was not possible because the limitation, the number of studies, we need at least 3 studies to undertake a meta-analysis. So this is a good example of a systematic review where you presented by a narrative form. It was basically presented without arithmetical, calculation. So I think this is a standard example. It is good for people to know that not all systematic reviews require a meta-analysis. If there is limitation of studies, you can simply have a descriptive presentation of the systematic review. That does not bring down the quality of your systematic review. However, the kind of studies that you have, and another thing that I noted was the risk of bias and the critical appraisal of your studies was not clarified. So each of the study that you included for your this thing, at least I missed it if in case you did say that. So the risk of bias has to be presented in a good graphical way so that one can eyeball it and see what is the quality. When you said the limitation of each study, every time the reason was the sample was small. What was the methodological limitation of each of those included studies is extremely important for us to know. So on the whole, I think it was a great learning exercise for all of us. Interesting. I think Madam said trust is very important for LMICs. I certainly do agree with that. However, we at the same time should not end up over treating people and thereby developing disease resistance and so on and so forth. So I think it is well said. We need more evidence in that direction. Thank you so very much.
Thank you, Dr. Sampat Kumari, Madam Saraya, and Dr. Radhika for your inputs. I would like Sujata is there as a chairperson. Can we have comments from her if she's around? Otherwise, I can comment. If she's there, I can, we can hear from her as a chairperson. So I must say that I must congratulate Dr. Vera for the excellent, systematic review. As Dr. Radhika has pointed out, some of the, points that we should have included, what should be done. But basically, this paper we have accepted in our JOGI journal, systemic review, that we want to have ideas that all gynecologists and obstetricians should know when the facilities, she has already mentioned about it, when the MRI and CT scans are not available or they are not, affordable, then this one form of transrectal, ultrasonography is very, very important to find out so many things like, what you say as cancer extension, pre-operative assessment, diagnosis with biopsy, assessment of chemotherapy, when they have radiotherapy, staging, intraoperative guided procedure, brachytherapy, and all these things it is involved. So this is what we felt as a peer reviewer, editorial team, and myself, we felt we should accept this paper. So all the gynecologists and obstetricians are aware that the transrectal ultrasonography does help in all these conditions to treat the patient, early diagnosis, and we can early cure, early diagnosis, early cure. And Dr. Vera has already pointed out some of the disadvantage where tumor more than 4 centimeters, etc. We have no chance, not much important over here. But we can, I remember when we were resident and we used to put a speculum when the postmenopausal lady used to come or PV examination, there used to be torrential bleeding. As a resident, I remember that. But at least transrectal can avoid this bleeding, torrential bleeding. So there are such many advantages, and our research will keep on going and will tell us that yes, transrectal is important, and she's combining it transperitoneal, transvaginal, and abdominal. So one thing I definitely know that we have seen torrential bleeding with PV examination, PS examination. So we have to continue, evolving in all these things, and therefore we said, even though it is, this article is, Saraya Madam is a pioneer in the cervical cancer prevention program, and she has said, preventable but not yet preventable. So we have our mission of FOGSI that, elimination, preventive oncology and elimination of cervical cancer. So these are the strategies we can adopt, and we can prevent the disease or we can cure the disease if diagnosed at the early stage. And this is, we have come out, madam, with the cervical cancer issue, where you have also written a review article. You must have received your SMS. We have uploaded on this cervical cancer issue, special theme-based issue, and therefore, Dr. Vera, she's a radiologist, she has done, and we have selected her, topic, and we have put in this special theme-based article of our journal. So I'm really thankful to all of you, Dr. Vera, and all the comments from all the chairperson, especially Madam Saraya and Radhika and Sampat Kumari. And if Sir Sanjay Gupta sir is still around, if he would like, or Dr. Lakshmi would like to have some comment, because this is a new things which everybody should know. Yes, Radhika.
I just wanted also to add a very small point. It would be also a good idea, other than having a systematic review of primary studies. So here the limitation was small size sample. So we could also consider doing an umbrella review. We can look at the literature to see other systematic reviews and collate the results of those systematic reviews. So I just wanted to bring home that point that there is something called an umbrella review also there. Thank you.
Thank you, Dr. Radhika. Dr. Lakshmi?
Yes, Madhuri, because transrectal ultrasound is really a good thing because we all have seen torrential bleeding in our postgraduate dates and in our beginning of the practice. So Radhika has already commented on the study part, but I feel ki yes, this has great logic as far as cervical cancer is concerned.
Thank you, Lakshmi. Yes, Sunil, yeah.
But at the same time, madam, as she presented, there were 10 cases where their perforations were noted. So again, this comes with a sort of, salt. But we must congratulate Dr. Vera, and Indonesia being Asian country, it is quite relevant to all of us.
Thank you, everybody. Thank you. I think we can move on our case report. That is the third presentation.
We request chairperson to introduce the next report.
Dr. Radhika, you can introduce, I think.
Dr. Radhika, madam, please introduce Dr. Divya.
Oh, I'm so sorry. Okay, so we are very happy to have with us Dr. Divya. She is from the Department of Obs and Gynae, AIMS, Deoghar, Jharkhand. She was awarded the first prize in PISA, Obs and Gynae, and she's got, at this young age, so many awards and so many presentations and published papers at national and international journals. So, and she is specifically interested in high-risk pregnancy and maternal medicine. And so a very warm welcome to you, Divya. Over to you.
Thank you, ma'am. Thank you, Madhuri Patel, ma'am, and all JOGI team for giving me this opportunity for presenting my case. Ma'am, I'm not able to share my screen. It's okay. Ma'am, whether my screen is visible?
Yes, your screen is visible.
Okay.
Make it a slide mode,
You
please.
can make it full screen, slideshow.
So my case report on adrenal crisis in a patient with autoimmune polyglandular syndrome during pregnancy. So moving on to the introduction. So autoimmune polyglandular syndrome is a autoimmune disorder. So there are 4 variants. And here we had a patient with autoimmune polyglandular syndrome 2 with autoimmune adrenal insufficiency and at least one of the autoimmune endocrine disorders such as autoimmune thyroid disease, type 1 diabetes mellitus or both. And the prevalence of adrenal insufficiency during pregnancy is 5.5 per 1 lakh pregnancies. So moving on to the case presentation. So we had a 26-year-old pregnant woman and she was not our follow-up case. And she was 5th gravida and she had a 1 live baby and 1 intrauterine fetal demise and 2 abortion. And she came to our OPD at 36 weeks, 2 days. And we did an ultrasound and found there was a fetal growth restriction. And she was a non-case of primary adrenal insufficiency and Graves' disease. And she was on propylthiouracil and prednisolone 5 mg once a day during the pregnancy. So regarding her past history, at the age of 12 years, she diagnosed with Graves' disease and was on oral neomercazole 2.5 mg twice daily. And a year back, the event, she had an episode of fever, vomiting, loose stools, and altered sensorium. And she was admitted in the general medicine department with hypotension, hyperpigmentation all over the body. And that time they suspected adrenal insufficiency and they have done investigations and found her baseline serum cortisol was very low. It was 0.7 microgram per deciliter and the normal value from 5 to 22. And with elevated ACTH of 411 picogram per ml. And they have done ANA and APLA, which was negative. And they have done CECT abdomen and pelvis and which showed bilateral hypoplastic adrenals. And hence they established the diagnosis of primary adrenal insufficiency. And that time they started, before doing this investigations itself with the suspected adrenal insufficiency, they started on parenteral hydrocortisone, and she had a drastic improvement with the hydrocortisone. And gradually they tapered the dose, and they have added oral fluorocortisone also, because she had a persistent hypotension even with hydrocortisone. And later on, patient gradually improved and switched over to oral prednisolone. So regarding the marital and family history, she had a non-consanguineous marriage at 19 years with no significant abnormal menstrual history. But in the family history, her mother had hyperthyroidism. So moving on to her past obstetric history. So first she had a missed abortion at 3 months, for which DNC was done. And second, a year later, she had an intrauterine fetal demise at 7 months, and the cause is not known. And third, she had an uneven full-term vaginal delivery, 2.5 kg female baby, and the baby daughter was good and with normal milestones. And fourth, 3 years later, she had a missed abortion at 3rd month, which was medically managed, and this was her 5th pregnancy. So she got admitted for fetal growth restriction, and following admission at the HDU, she had a altered sensorium, abnormal movements, hypotension. And when we checked her blood sugar, it was 70, and she had fever also 101 degrees Celsius. So there was a confusion regarding the diagnosis of whether it's eclampsia or not, but she had a hypotension, like systolic was 80. So because of this background history of adrenal insufficiency, we suspected adrenal crisis and give parenteral hydrocortisone 100 milligram. And for the fever, we gave paracetamol infusion too. And we saw that she got gradually improved with this treatment. And then we tapered the steroids to 50 milligram 8th hourly. So she got admitted 36 weeks, 2 days. So after 3 days, stabilizing the patient. So we planned for induction because of FGR with normal Doppler. And as she had 2 prior deliveries, so we induced with Foley's, followed by oxytocin augmentation. But she had a pathological CTG, and emergency section was done, and delivered a 1.4 kg female baby. And the baby was handed over to pediatrician for ICU care in view of low birth weight. And regarding the postpartum period, so she had 50 milligram, 100 milligram to 50 milligram 8th hourly. And then the hydrocortisone was tapered and changed to prednisolone and fluorocortisone by postoperative day 3. And during the 3rd postpartum day, she had hypokalemia, for which potassium correction was done. And then the period was insignificant. She was on prednisolone, and both mother and baby got discharged on postoperative day 20. So moving on to the discussion part. So autoimmune polyglandular syndrome are of 4 types. And in autoimmune polyglandular syndrome 1, it's a juvenile APS, which will present with candidiasis and ectodermal dystrophy. And in APS 2, 3, and 4, it's adult variant. And in APS 2, there is autoimmune adrenal insufficiency and at least one of the autoimmune endocrine disorder like autoimmune thyroid disease, type 1 diabetes, or both. So in our patient, she had autoimmune adrenal insufficiency and autoimmune thyroid disease, that is Graves' disease. And in APS 3, there is autoimmune thyroid disease and type 1 diabetes mellitus, but without affliction of adrenal gland. And type 4 APS is a diagnosis of exclusion with 2 or more organ-specific autoimmune endocrine syndromes, and which is not assigned to APS 2 and 3. So regarding adrenal insufficiency, it's a rare and life-threatening medical condition during pregnancy. And this adrenal insufficiency are of mainly 2 types, primary and secondary type. And in primary type, it due to the destruction of adrenocortical cells in the adrenal gland. And the secondary type due to the impaired adrenocorticotropic hormone secretion from pituitary or hypothalamus. And the causes include autoimmune disease, infections such as tuberculosis, hemorrhage, tumor, etc. So regarding the diagnosis of adrenal insufficiency in pregnancy, so diagnosis of adrenal insufficiency during pregnancy is mostly can be misleading as they mimic the normal physiological complaints of normal pregnancies like nausea, vomiting, dizziness, and easy fatigability. And when we do an laboratory parameters, we will be seeing hyponatremia, hyperkalemia, and hypoglycemia. So hence serial monitoring of blood pressure and blood glucose should be done. But in pregnancy, hyperkalemia is not expected due to increased renin, angiotensin, aldosterone system. And according to Endocrine Society guidelines, recommend the clinical features of adrenal insufficiency with serum cortisol cutoff less than 3 milligram per deciliter are diagnostic during pregnancy. So regarding adrenal crisis, it's defined as presence of at least two features: hypertension of systolic less than 100, nausea, vomiting, severe fatigue, hyponatremia, hypoglycemia, and hyperkalemia. And it should be diagnosed rapidly and requires parenteral glucagon administration. And adrenal insufficiency in pregnancy, it can cause some adverse effects too. So it can cause increased incidence of preterm delivery, cesarean section, impaired wound healing, infection, and thromboembolism. And hydrocortisone is the preferred treatment. Adrenal crisis is expected more during labor, delivery, and immediate postpartum period. And regarding the fetal part, metal antibodies may cross the placenta, but not sufficient enough to cause neonatal adrenal insufficiency. So moving on to the main part, it's the treatment. So hydrocortisone is the treatment of choice. So starting with 12 to 15 milligram per meter square or 20 to 30 milligram per day in divided doses during the first and second trimesters. And fluorocortisone dose 0.05 to 0.2 milligram per day, which depends upon the blood pressure and serum potassium level. During the third trimester, hydrocortisone can be given up to 40 to 60 milligram per day and fluorocortisone in the same dose. Routine therapy can be continued till the onset of labor. And during labor, hydrocortisone should be doubled. So we should give 50 to 100 milligram of parenteral hydrocortisone. And if planning for cesarean section, then 100 milligram IV hydrocortisone should be given 6th or 8th hourly. And in case of adrenal crisis, 100 to 200 milligram IV hydrocortisone followed by 50 to 100 milligram every 6th or 8th hourly along with fluid resuscitation required. And in case of hyperglycemia, 5% dextrose should be given. And in case of hypokalemia, potassium supplementation should be administered. And postpartum period, we can taper the steroid to pre-pregnancy dose, and this can be done within 3 days. And this hydrocortisone is found to be safe during breastfeeding. So moving on to the conclusion. So this was a case report of successfully managed adrenal crisis in a pregnant woman with autoimmune polyglandular syndrome. As we are getting more of medical disorders in pregnancy, and we need a more suspicion and diagnosis should be done, then only we will be able to save the patient. And diagnosing adrenal crisis even in an established case of adrenal insufficiency is perplexing and mandates strong suspicion, as this can be easily confused with the pregnancy changes and symptoms. Early diagnosis and initiation of empirical treatment with glucocorticoids with careful monitoring are essential for rapid recovery of these patients. So I thank my professors, Dr. Jayalakshmi ma'am, Haritha ma'am, and Changavirappa sir. Thank you.
Madam, stop sharing.
Over to chairperson.
I think it was a very well presented case along with the discussion period. I must congratulate you for that. And it's like you said, a rarity, and it was actually a learning exercise. The diagnosis, the presentation, the entire aspects of it, including the discussions. I really do not have any specific queries. I just learned from this presentation. Thank you.
Thank you, ma'am.
Dr. Sampat Kumari, Dr. Sujata, Sanjay Gupta here, Dr. Lakshmi is here. Anybody who would like to comment? If there's no comment, then I would like to say that Dr. Divya has presented very well, which is a very, very rare case. And sometimes we keep on treating the patient, they don't respond. Then you how to remember certain, such type of situation that, she's not responding and we should, refer, or we can ask our, colleague to, to give their opinion. So it becomes very, very easy. We don't miss out. And as you have shown very well, that by just giving a corticosteroid, because you could diagnose this condition, and the corticosteroid has really helped her to come out from the tight situation. So this is a very lesson learned, that you don't ignore. Many times patients keep on complaining, doctor, nothing is helping, nothing is helping. But we say no. We feel that it is something, psychologically or something is upset and this is happening. But we should not take any condition lightly, because patients are smart, they know what is happening to their body, which doctor doesn't know. So the whole idea, take home message is, take the patient's symptoms very, very seriously. And if you can't diagnose, then you ask your colleague or refer to the person who deals with that. So that is a take home message, I will say. And at the end, would you like to, Pragna, both Pragna, Sunil, would you like to comment? Then we can wind up our, this webinar.
Madhuri, I want to say that it is a very well prepared and well managed case. We learned a lot from this case.
Yeah. Initially, I was thinking that we'll give only original articles, but then we felt that the cases are also very, very important.
Yes.
And this time, instead of original article, last 6 episodes, we had done a original article. This time, we took one systematic review and 2 cases. So something different which our viewer can, hear, see, and implement to present such papers where, they can definitely get motivated. So very nice. And Pragna Changade was after me, madam, we must take case reports. I said, okay, we'll take the case report with the systemic review. So both Pragna and Sunil were just after me. I said, okay, we'll do it, So I think lesson learned are quite good today's webinar. So anything, both Pragna and Sunil can wind up then if everything is okay.
We congratulate you, Dr. Divya, very well presentation. So it gives us a message that, as madam said, vague symptoms you cannot neglect. In cities, we have endocrinologists. They can very well evaluate, but in low resource settings, in this case, serum electrolytes, fetch the diagnosis, to be very frank. So this is message to all the clinicians. Serum electrolytes, getting the test done. Thank you, everyone.
Thank you, sir.
Very good presentation. And I think for rare cases where we don't have plenty of them, but we are stuck up at managing or knowing how to manage rare cases, I think case reports are the way to go. Of course, original articles are preferred. But when cases are very rare or atypical, we cannot have plenty of them to present as original articles. So I think it's a good thing that we have kept case reports as well as meta-analysis, because each has their own role in research and publication. So thank you so much, Madhuri ma'am, and thank you all the speakers.
Thank you. See you on the 3rd Wednesday next month, 4 to 6.
Yes.
Okay. We'll
Yes.
be happy.
Thank you, madam.
Thank you, and Dr.
Thank you.
Sampat. Thank you, Dr. Radhika, Dr. Lakshmi, Sanjay Gupta sir, and Saraya madam. Thank you, everybody.
Thank you. Thank you.
Thank you, madam.
Thank you.
Maria, thank you. Maria is
Yeah,
the most important pillar of my journal, and thank you, Maria,
Sure.
for doing all the work and making it easy for me and our editorial. I'm editorial secretariat team. Thank you, Maria.
Thank you, everyone.
Thank you.
Thank you.
Thank you, everyone.